progress. And this disease is not just our disease right now. We have some problems with the Hidranitis fistula. First of all, I have no conflicts regarding to this presentation. It was first described 200 years ago with a surgeon named Verneuil. It's also this disease is called Verneuil disease as well. But we understood the mechanism in the 20th century, and then we know this disease as a Hidranitis fistula. And Shelley and Ken were able to demonstrate the scientifically that is non-inflammatory disease also affect brain civic glands. Yes, the abscess that keeps coming back in those patients always. You are already treating disease in the emergency rooms with the abscess, drainage, incision and drainage, and we're given an antibiotics and sent them home as soon as possible. But the patients comes again and again in the emergency rooms, and they will never understood the real reason of this problem. Recurrent painful nodules, abscesses, and especially it's in the groin, buttocks, and the perineum. Drain and drain again, and knee scar every year. This also happens. It may cause also a secondary problems such as an unalignment, hygiene problems, and also numbness, and also they took medical leave for the year, at least approximately 40 days in a year regarding to those studies. Also, they are active employments. Also, these are mostly men are. Till 2016, this is only an advanced surgical problem, and after that, we faced with the new drugs, adalimumab, and also after that, secukinumab, bictegravir. Lately, a new drug is called povorcitinib. It's an oral drug, just preventing the inflammation. Is it just only the inflammation? Yes. This is a very important thing. For the case, we had nothing to do except the surgery. After 2016, adalimumab is the first drug ever approved for this disease. 7 years of silence after the adalimumab, we faced with the secukinumab because the mechanism consists also TNF blockage, and also the treatment is related with the interleukin 17 alpha. In 2024, they combined interleukin 17A and F, and together, and then also 2026, on this March, we have a new drug to JAK1 inhibitor. And this is the first oral target agent in the medicine. Why the drugs work and why they are not enough in this disease? If you look at the pathophysiology, you see the four steps of the mechanism. The first step is the follicular occlusion. The terminal hair follicle plaques in the naproxen-bearing skin. The gland is bystander, not the culprit. Rupture of the abscess, keratin and the bacteria spill into the dermis. The immune system meets the material it should never seen before. And run away the inflammation, self-sustaining TNF alpha or interleukin response. This is the part of the drugs can switch off this disease. But at the end, there is a remodeling of the disease and the tissue, the tunnel formation, the epithelialized, permanent, self-perpetuating form of the inflammation. This is the part that the drug cannot touch. According to this pathophysiology, you see that drugs calm the inflammation. Only surgery removes the tunnels. You see the results of the new drugs compared to placebo therapies. First drug was the adalimumab. You see the red bar. They have a very good response. According to Hidranitis clinical response rate, 50 response rate. It means that before the treatment, if you get the 50% of regression of the inflammation, you are successful according to this classification. You see that there's a high response to the medications, but if you compare with the placebo treatments, they are still response to the placebo. It means that during this disease history and the progression, there's a relief and also flares. They work when they decrease the inflammation, but if they are silenced in the silent mode, they will not affect. And also, it will never affect the tunnel at the tunnel stage. This is the latest information coming from the presentation and from the company. It's an oral drug. They have a very good response for the 50% of regression of the clinical response. And they are very good for the 75% of response for the inflammation, but not very good at this 100% of inflammation regression. And also they will never relieve the tunnel formation. Why a surgeon should care? It's a tablet, no injection, no need to give additional progress and phobia. And also you have to work with the dermatologist. It still works after anti-TNF failure. If you use adalimumab, and if it fails, you can use it very well. But the tunnel formation is a different thing. The tunnel is an anatomy, it's not an inflammation. It's cutting the tissue is not working alone. Injection is not working alone. You have to combine the both modalities. And you have to know whether medical therapy is such for the inflammation, and the surgery is for the irreversible tissue damage. Also, perineal hidradenitis suppurativa is not always hidradenitis suppurativa. You may get a misdiagnosis, and sometimes you may face with the chronic Crohn's fistula. You may face with the Crohn's fistula, or you can diagnose the Crohn's fistula as a hidradenitis suppurativa or vice versa. Because all the treatments are working together, anti-TNF drugs and other drugs work in Crohn's disease. But there are some differences between each other. In Crohn's fistula, tracks deep to the internal opening into the anal canal. There is no anal canal involvement in the HS. Bowel wall involvement, rectal thickening, often complex, often anterior, often with the proctitis, the fistulas. And metastatic Crohn is a further mimic. And radical surgery, here's a different decision entirely in the Crohn's fistula. Imaging is not for the diagnosis, imaging for the differentiation, and also giving a decision for the surgery. Diagnosis is always in the clinical setups, and also you can use the ultrasound plan for the decision for the surgery. MRI will give an answer for the question. Is it a Crohn's disease or another thing? Or sometimes a staging and a cancer on the setup of HS. Oh, as a surgeon, match the operation to stage, not to the reflex. You cannot do it's the same operation for all the stages of the HS patients. Mostly we do the incision and the drainage for the acute abscess. It will only relieve the pain, and recurrence is 100%. De-roofing is the simple thing. It will for Hurley 1 and 2 stage, and it will discreate the recurrent tunnels. There's a new modality. Modality is a skin tissue preserving electrosurgery technique. It will affect, you can use it with the Hurley 2 and the 3 to very alternative, and there's a very low recurrence rates. White excisions, even if it's white excision extensive, turn out to the Hurley 3 stage, there's still recurrence rates. How we do this deroofing, we insert the style, and then we find the tunnel, and we cut the roof of the tunnel, and we drain it, and we curate it, and leave it open. And you will see the final result 2 weeks later. You will see the granulation. Maybe it will never work. This kind of patient, this only 3 patients with a scar formation, tunnel formation. The inflammation is over, and there's no inflammation, but there's a scar tissue, and all those drugs will not work to heal this problem. And still there will be drainage from the tunnels. This is a hygiene problem. You have to remove all the affected tissue. You can close with the primary or from by the skin grafts as well. Do not stop the biologic to operate. Yes, we use the biologics, and then as I told you before, we have to combine the treatment therapies. According to our inflammatory bowel disease experiences, we have to stop the anti-inflammatory drugs and the biologics at least 2 or 3 weeks before the surgery, but it is not working in the HS. If you stop the biologics before the surgery, 3 or 4 weeks before the surgery, the disease will be delayed, and there will be a more acute response and then more inflammation, and it may recur suddenly. Okay, we resected, we do the white resections, white excisions for the HS. How can we close the defects? The answer is defect shows us the closure techniques, not the surgeon. We published our results in 2009, and we used very different modalities. We used the vacuum-assisted closures, we used the rotation flaps, we used the white excisions for the secondary closure. Also, we combined the late skin grafts. And you see a very different kind of the closure techniques. There's no one solution. Okay, there's another question. Do I need to divert those patients, even if there's a white excision around the perineum? According to our experience, we didn't do any diversion to the colostomy or the ileostomy for those patients. But today, according to the literature, there are 40% of diversion. I think this is not a very good option for those patients. But there's a problem with the fecal infection or the anal sphincter infiltration. You have to deal with you have to think about the diversion. Okay, there's one important situation in this particular patients that you cannot afford to miss it. There's a cancer formation. There's a very long setup for the HS patients, approximately history of the 2 decades. You have to think about that there will be a squamous cell cancer formation. 47% of those patients are originating from the gluteal area. Mortality is high, and the metastasis rates are high. You have to biopsy anything chronic, indurated, and non-healing or rapidly growing tissue when you did even if you did it in excessive excisions. In conclusion, you have to stage the disease. You have to calm it with the anti-inflammatory drugs and the biologics. And after that, you have to cut what is left. Then keep watching. There's a very high recurrence rate, even if you combine those modalities. Yes, in conclusion, ladies and gentlemen, this HS is not a medical disease. Also, it involves with the surgical disease. We have to control the inflammation with the drugs. We have to remove the tunnels with a knife. Do both, not one only. And we don't need to stop the biologic to operate. We have to match the operation to the stage, early 1 to 3. Mostly we are dealing with the early 3. And perineal HS is not always HS. It may be confused with the Crohn's disease. And also we have to think about the perineal squamous cell carcinoma for those patients. Thank you for listening to me, and visit our board for the International Society of University School and Rectal Surgeons. Thank you.
Thank you very much, Professor Malik.